Hello everyone, welcome to this webinar. Um, this webinar, I'm going to discuss about patient preferences for stroke outcomes in India, implications for physiotherapy. Uh, I hope there won't be any technical trouble in this webinar. In case if you find a technical trouble, please look into the comment section. We will be posting what to do if in case. Uh, The outline of this webinar, there are two things that we will be discussing in this webinar. The two keywords that is part of the title of this webinar. One is patient preference, and second is implications to physiotherapy. So patient preference, basically what matters most to our patient with stroke, that is after stroke, what is so important for them, and how we can integrate that outcome, the outcome that our patient consider important, into our treatment decisions. In this, whenever I say our, I mean physiotherapist. So how we are looking at patients with stroke. When a patient with stroke, when we treat them, and how we see their problem. Mostly our perception of stroke or patient with stroke is that their problem is more from an impairment focus. We look at it, that is such as they have hemiplegia and spasticity, abnormal synergy, such as circumflex gait. So this is how we see their problem. And in this case, our outcome, so we see this as a problem, and we generally work to produce an outcome which is a normal movement patterns. That we consider abnormal movements as a problem, and we set outcome as normal movement patterns. However, does our patients also look at their problem this way? The answer is not exactly. So what matters to our patients? This is what we have put it, the contents in here is based on one of the ongoing study that we are doing, that is looking into patient preferences and what outcome they're interested. And I hope many of you, if you're working in stroke rehabilitation, will also agree that these are all something matters to our patient. The first thing, especially in the early stage, what matters most to them is mobility and self-care. That is walking and going out, go to toilet, take bath and dress themselves, and other self-care activities. Further, they are also interested, and they also consider important is to return to work, especially if it's a male, and also in case of female if they're going to work. And other family roles, such as if they're a homemaker, they want to be able to cook and carry out their household activities, and maintaining their social life that they have had before stroke. Some of the common socialization activities that our patients are interested in, such as visiting temple, friends or relatives home and chat with them, and go to park and restaurant as a leisure activity, and attend weddings and other social and family ceremonies that they are interested. And if you look at it, you all are very well aware that these are all very specific to an Indian context. It may not be the same in other contexts, but since we are looking at this entire idea of patient preference within Indian context, so this is what is more common. If any of you who are listening found that something can be added, or you have a problem with some of the outcome we mentioned, please interact with us during questioning. And other important issue about these outcomes is, what do they want these outcomes? They want independence in doing this, and they want to be safe while doing it, especially if they're going out, they want to be safe, and so that they will not fall when they go out, and also satisfaction in fulfilling their family roles and maintaining social life. So if I just to summarize what we have discussed until now is, as a physiotherapist, we look at patient problem in terms of mostly their neurological symptoms and impairments, such as hemiplegia abnormal synergy and circumdactic gait. But what matters to our patients is that they look at their problem that are closely related to their day-to-day functioning. So uh, in earlier, maybe after before 50 years or so, people used to believe that if we change those abnormal patterns, this functional activities will automatically get better, that there will be carryover effect of impairment-based training into functions. But now we know for sure that there is a mounting evidence suggests that that transfer doesn't happen. So which suggests that we have to focus on getting back these activities. So, like I said before, since because many of us think that abnormal synergy or abnormal movement patterns are a problem, and there isn't much discussion with the patient about what matters to them, and which has led to many such problems, such as cooking or return to work, and these things they go underreported, underrecognized, and consequently undertreated. Say, for example. We generally don't treat patients to return to work, or don't treat patients to get better in going to toilet or cooking or household activities. Our treatment outcomes are often based upon reducing spasticity or abnormal movement pattern. So this several study results are suggesting that there is a discordance between what physiotherapists and patients see as important. So we have very good evidence suggesting that this is a real problem. There is a mismatch between what physiotherapists think as an outcome and what patients expect as an outcome. So therefore, uh, we believe that the patient preferences should guide the selection of treatment goals and outcome. What this means that we have to identify what matters to them most, and then our treatment goals, or we have to set that as our treatment goals and outcomes. So we have to work on treatment strategies that will produce this outcome. And so it is imperative that we keep their goals in their mind, in our mind, when we decide treatment outcome. So keeping this as a background, that we have started working on a research project in which it's a larger project, but we are looking at part by part. So one of the major part of that research is to find out what matters to our patients. When I mean our patient, means patients in India. Within Indian context, what are all the outcomes our patients are interested in? So one of the major difference between Western culture and our culture is sitting on the floor and squatting, and its relevance to many of the daily activities we perform. So I think this is something everybody knows, but I would still insist on uh, discussing about this. That in India, especially in the rural region, many of our everyday activities are conducted at the floor level, and this require squatting and sitting on the floor. Some of the example of those activities are eating, bathing, taking a bath, washing clothes and utensils, toileting, and other social gatherings such as attending a wedding or meeting friends in their place and chatting, and many essential activities of our daily living requires us to squat or sit on the floor. So this is one class of activities that are especially important in our context. However, in stroke rehabilitation, we focus mainly on helping patients to sit up and get up from chair or bed. This is something in contrary to what patients want. That is, On one level, patient wants to sit on the floor and squat, but when it comes to treatment, our focus tend to concentrate on sit and get up from chair or bed. So why this discrepancy? We have thought of many reasons, but we have come to a conclusion that the major reasons are two. One is most of our practice knowledge about stroke rehabilitation is influenced by the Western literature. The textbooks that we read, the articles that we go through, research articles, they're all mostly from Western literature. And in Western culture, sitting on the floor or squatting may not be a preferred activity, in a sense that it may not be on their priority list. So if you look at many of our textbooks that we have read during our education or even after that, you hardly find information related to uh, uh, problems in squatting or treating a patient to sit on the floor. Except for one book which is recently published, it is focusing on Indian context, written by Mr. Hariom and Vasantan, one of the co-author of the study, that squatting is considered. Other than that, most of the textbook does not really focus on it. Other recent what we found is that is when we discussed about this, many of our colleagues who are working in stroke rehabilitation, and they have said that uh, reasons why we are not focusing on it is most patients may not wish to do deep knee flexion activity after stroke. That is, they may not be interested in doing that anymore, and so that we don't have to consider that as a goal. Another reason they provided is recovery of deep knee flexion activities, that is squatting and sitting on the floor, is very unlikely because it is a physically exhausting activity, and many patients with stroke may not be competent enough to perform it. So this is what clinical assumptions behind why we are not focusing this. So we wanted to test this assumption and to find, is it something our patient wants to do? Do they consider this as a important goal? So for that, we have conducted a study which is recently published in the journal Topics in Stroke Rehabilitation. In this study, we surveyed 123 patients with stroke and asked them post-stroke whether it is important for them to perform squatting and sitting on the floor in their daily activities. And what we found was 68% of participants rated deep knee flexion activities as very important for carrying out their daily activities. Out of this, the major activities that has come up is toileting, bathing, eating, praying, and work. If you look at toileting, 78% of our patients have identified this as one of the goals. And praying, many of this again, it's very context specific to India, or that these things and work, many patients have identified this as very important. In addition to that, we have also found certain gender differences in terms of activities they considered as important for them to squat. The squat, especially cooking, cleaning house, and washing clothes. These three activities, female have predominantly identified this as important activities. So what does this study result mean? That this, what we think is, because majority of them have identified that squatting and sitting on the floor is important for them in several daily activities, we believe that as physiotherapists working in stroke rehabilitation have to consider this as a potential goal, that is squatting and sitting on the floor as a potential goal. And we are aware that it may not be a preferred goal for all the patients. However, during the initial interview process with the patient, we have to give them a choice. We have to ask them whether squatting and sitting on the floor is a goal for them. And if they consider this as a goal, then we have to be providing treatment or developing treatment to achieve that goal. As I mentioned earlier, there isn't much information on how to uh, uh, improve squatting and sitting on the floor. So 3 years before, we have developed a treatment program and exercises and applied it on one patient and found that there is a significant amount of improvement in squatting and sitting on the floor. This particular training program we have developed is based upon the contemporary motor control theory, which is a dynamic system theory, and it contemporary motor learning principles were integrated into it, and using task-oriented exercise as a paradigm we have developed. And if you're interested to know what exercises we have actually given, please mail to us. At the end of this webinar, the last slide, we have mail IDs of Mr. Hariom and myself. You can mail to us. We can send the full text article about this. So, however, as I mentioned, it's a single case report. It may not be sufficient enough to say that this treatment it actually works or it should be implemented in clinical practice. So after the case report is published, now we are developed a RCT protocol, and we are presently conducting a randomized controlled clinical trial to evaluate the efficacy of that exercise in improving their activities of daily living involving deep flexion and quality of life. This randomized control trial is presently ongoing, and if any of you are interested to participate in this trial, physiotherapists, you can contact us. We will be very happy to work with us to make this to complete this trial. For this, we'd like to acknowledge Dr. Susan Harris, Professor Emeritus from University of British Columbia, Canada, and Mr. Sudha Krishnan and Mr. Zafar Azim. All of them have played a significant role in the research that we conducted. For more information, you can mail to Mr. Hariom or myself. And if you have more questions or if you have comments to make, please type in your comments about this into in the question section. I'll be very happy to answer. Thanks for listening.